webinar series. Technically, actually, it's not a webinar. Anyway, this is the third day. Today, we are going to discuss about management of breast lump. Today, our speaker is Dr. Nalinda Munasinghe. You know him. He's the head of the department, Faculty of Medicine, Ragama. He's a board certified breast surgeon, general surgeon with a special interest in breast surgery. Other thing is he's a leading surgeon. He has a lot of academic activities. Therefore, he is the best one to talk about management of breast disease. Dr. Nalinda Munasinghe.
Hello. I'm trying to share the. Can you hear me?
Yes, Nalinda, I can hear you. I can hear you,
Right,
Nalinda.
okay. I'm trying to share my presentation. Can you all see the slides?
Yes, sir, we can see.
Right, wonderful. Right. So, so we will go through the breast cancer, some cases which will be most likely to appear in your lung cases as well as your SCQ papers, and sometimes even checked in your MCQ knowledge as well. First of all, I'll give a brief idea of the principles of breast cancer or breast lump management. And we will take case by case. And at the end, I will show you some photographs because probably some of you are not familiar with these, some of the surgeries that we perform in a referral center. So any breast lump, whether it's benign or malignant, clinically, how will it proceed? The golden principle is triple assessment. So 3 things is assessed. First is very important, the complete history, including the risk factor assessment and including their family history. And not only when I say family history, not only the breast cancer, but also the cancer syndromes, which is breast cancer is part of it. For example, breast, ovarian, colon, and sometimes thyroid CA, they come as a familial tendency, although no genetic involvement. Then the complete physical examination. The next step would be imaging. Irrespective of the age, all will need an ultrasound scan, but that is a very focused assessment. Patients who are age 40 and above, remember, it's 40 and above, not 30, not 35, not 30, it's 40 and above, will need 2 mammograms, bilateral mammograms, with 2 classical views, craniocaudal view and the mediolateral oblique. And if there are any concerns, they will do tomography or any compressed views or any special views. But the classical views, that is the mediolateral oblique and the craniocaudal views, will be done in both breasts. The reason that we don't do mammograms for patients who are age less than 40 is merely due to their breast density, and we won't be able to read the mammogram even if we do it. But there are exceptions. For example, if we diagnose a patient with breast cancer at the age of 37, 38, or 39, done the ultrasound, done everything, the biopsies, everything done, now the breast cancer is diagnosed. In those patients who are already diagnosed with breast cancer, we might do a baseline mammogram for surveillance purposes, not to diagnose. Those are the exceptions. Otherwise, mammogram will be done 40 and above. And if you're doing a mammogram for a patient who qualifies for a mammogram, you do the mammogram first, which is followed by the ultrasound scan, because ultrasound scan, remember, it's a focus assessment. Any lesion or pathology that you suspect clinically or mammography will be further assessed by ultrasound scan. The third component is the histology. It is not cytology. It is histology. It's always for a solid lesion of the breast, the golden principle is to do an ultrasound guided, or I would say image guided, because sometimes, rarely, some lesions are not seen with the ultrasound scan, but is seen only with mammogram. For example, DCIS, the focus of DCIS. Microcalcifications are seen with mammography images, but not with the ultrasound scan. In that case, we do a mammography guided, or the technical term is stereotactic guided, or biopsies. Otherwise, all the solid lesions, we do ultrasound guided biopsies. Nowhere now, no longer we practice clinical core biopsies, right? But I do understand, but some of the centers might not having facilities to do image guided biopsies. In that case, you might do a clinical core biopsy, but on principle, we don't do clinical core biopsies anymore. So in the exam, if someone asks, yes, you will tell you will do an image guided core biopsy of the breast lesion. But you can see I have put with or without cytology within the brackets. That is to say, if you find a lymph node, clinically palpable, or ultrasound images shows you a lymph node, you can do an image guided FNA of that lymph node. Otherwise, it's only core biopsies for solid lesions of the breast. Is this slide clear to you all?
Yes, sir.
Yeah, okay, good. So the next step, how to treat breast cancer. So these are the basic principles. So surgery, we can do surgery and remove it from the breast and remove lymph node from the armpit, the axilla. We have radiotherapy. We have chemotherapy. We have endocrine therapy. Now we have targeted therapy. And beyond that, we have even progressed to immunotherapy. Sorry for that spelling mistake. It should be immuno. So surgery and radiotherapy is both are designed for local disease control, right? And the rest is designed for systemic control of the disease. Chemotherapy, endocrine therapy, targeted therapy, immunotherapy. So one targeted therapy is trastuzumab for HER2 positive patients, right? So the rest of the discussion is based on how we organize these treatment methods, which ones to be selected for which patient, likewise, right? So when you're talking about surgery in breast cancer, it has two components. What is the surgery that you are going to do to the breast? Next, what is the surgery that you are going to do to the axilla? Okay. So if we concentrate on the surgical options for the breast, first comes the breast conservative surgery. If to tell about a little bit of the history of breast cancer management, in 1870s, Mr. William Halsted from America, he described the Halsted radical mastectomy, where you take the entire breast off, including the skin, nipple area complex, breast parenchyma, pectoralis major, pectoralis minor, level 1, 2, 3 axillary clearance, divided the clavicle. It's a very high morbidity, mutilating surgery. But that was the understanding at that time, to debulk as much as possible. But over the years, breast cancer surgery has evolved so much that we no longer practice that sort of mutilating surgery, even for an advanced cancer. So I want you to understand this as a principle. And We now try to preserve the breast as much as possible, because now we know that the science and technology is advanced. It is not the breast that is going to give you problems in the next surveillances. The recurrence is not merely going to happen in the breast. Recurrence is going to happen elsewhere. So if the cancer is not locally advanced, you will try and preserve the breast. So breast considered surgery is the global standard for early breast cancer for T1, T2, or T3, not negative or not N1, right? When you tell the breast considered surgery, that's a bit of an umbrella term. Within that, you get wide local excisions and the contractectomies, right? The next one is mastectomy. So mastectomy, when I say, you know what is the mastectomy, the commonest thing that is a total removal of the breast, including the breast parenchyma plus the nipple lateral complex and the skin envelope. That is the, some say the total mastectomy or simple mastectomy that we say. We don't remove any pectoralis major muscle or minor muscle or divide the clavicle. We don't do those. No, those are gone. Those are long gone. Those are history, right? Forget about it. Now, there are people who qualify to do this sort of a mastectomy because the disease is advanced, or it's their wish. Patient wishes to get the entire breast off. But equal results are given by what is called the conservative mastectomies. Now, conservative mastectomy means we are conserving something but doing a mastectomy. So the mastectomy here involves removal of the total breast parenchyma. Then what are we conserving? We are conserving the skin envelope, include the nipple lateral complex, then it will be called a nipple sparing mastectomy. Or else, sometimes we have to sacrifice the nipple lateral complex because it is intimately involved with the cancer underlying. So we will sacrifice the nipple lateral complex with the breast parenchyma. Then only we will be conserving the skin envelope without the nipple lateral complex. Then it is called a skin sparing mastectomy. And I have put therapeutic and prophylactic in front of nipple sparing mastectomy because in case of gene-positive breast cancer patients, the nipple sparing mastectomy will be done as a therapeutic option, if possible, to the ipsilateral side, and to the contralateral side, we do what is called prophylactic mastectomy, nipple sparing mastectomy. Can you kindly ask questions if you have any up to this slide?
So breast conservative surgery cannot be offered if it's locally advanced?
Yes and no. That all depends on the breast volume as well. So if you're talking about a larger breast and the cancer is 4 centimeters, still we can go for a breast constitutive surgery because the breast parenchyma is enormous. So we can mobilize it and do a therapeutic mammoplasty or fill in the gap with what is called the chest hole perforator flaps. I will show you some examples. But same cancer, 4 centimeters, in a smallish breast, like a cup B breast, then that will be a greater challenge because more than 70% of the tumor will be involving the entire breast. In that case, we might have to do neoadjuvant chemotherapy, downsize and downgrade the tumor, and see how it responds, and then do a breast conservative surgery if the patient is very adamant in preserving her own breast. Or else we can offer other aspects like nipple sparing mastectomy with reconstruction. So it all boils down to what the breast size and the tumor size and what is called the breast tumor ratio. Did I answer a question?
Yes, sir. Thank you, sir.
Okay, shall we move forward then? So next question, what are the surgeries done to axilla? Now, traditionally, it was an axial clearance or axial lymph node dissection. Now, we do that surgery only for the patients who have been diagnosed to have positive nodes in the armpit, either clinically, radiologically, or sometimes if you're not sure, you can even do a FNA, image-guided FNA of the lymph node to see whether it's really node or not. So if the axilla is clinical, radiologically, or cytologically positive, we will do a axial lymph node clearance. Or else, we do a sentinel lymph node biopsy. Because over the years, we have understood that remove the entire lymph node basing in the axilla is not going to help you overcome the cancer. In fact, lymph nodes are your soldiers, saviors in the armpit. They are the natural blockade against the cancer cells, right? So unless they are diseased themselves, there's no point in removing them. The knowledge that we try to gather from lymph node surgery is to determine the subsequent systemic therapy. For example, if the nodes are really involved, histologically proven, then they will need systemic chemotherapy. But if the lymph nodes are not involved, you don't need to give chemotherapy. But there are other aspects of determining chemotherapy as well. But regarding the lymph nodes, if they are not involved, then there's no need to give chemotherapy because the lymph nodes are not in. But there will be other reasons, right? The problem is axial dissection or axial lymph node clearance gives a lot of comorbidity to the patient. The chance of developing ipsilateral lymphedema of the upper limb is more than 45 to 50% for the next 5 years who have undergone a level 2 clearance, right? Where if I compare with the central lymph node biopsy, the risk of developing lymphedema in the ipsilateral upper limb is only 10 to 15%. So that is very significant, isn't it? And apart from that, it's not the lymphedema, it's the heaviness and the discomfort that the patient carries with the lymphedema and the recurrent infection. And also chronically, they are having a risk of developing lymphosarcoma, the limb. And the range of mobility, movement of the ipsilateral shoulder joint is also going down, right? So a lot of morbidities that comes in hand with the axial clearance. So that's why the world has differed from that unless the lymph nodes are clinically and or cytologically proven to be involved. Okay, so central lymph node biopsy, how you do? The idea is to remove the lighted up nodes in a blue dye, in methylene blue dye or barium blue dye, but we have in Sri Lanka what we have the 2% methylene blue. You can give it subareolar injection at the start of the surgery, and you do a breast massage for 10 minutes. Then you open up the axilla, you will find the lighted up node. Or else sometimes when if the tumor is sitting at the right at the upper outer quadrant where the axillary tail is, there's no point. Still you can give the subareolar, but sometimes you can give peritumoral as well. The central lymph node biopsy, when you do, you need to understand it's not only the theoretically it says the first node that drains the breast, but over the years people have studied and understood. But removing only the first node, if you do that, you will have a higher rate of false negative rate. So now the idea is to remove all the lighted up nodes. It could be 3, 4, and they have identified if you remove 4 or more nodes, the false negative rate drops down to less than 9%, which is the accepted one, right? Or any other palpable nodes. If you have large nodes, you can also take them as non-sentinel lymph nodes, but you don't have to do a clearance, right? Any questions about axillary management? So single tracer method is what we do in Sri Lanka. We do the blue dye method. Sometimes we had a radio tracer as well. Technetium 99 level radio tracers, but it's not now available in the the government sector. If you have both the blue dye plus the radioactive tracer, you can do the dual tracer technique. Otherwise, the single tracer technique is well accepted. It gives good results. So, can we discuss this first case, if you all are happy? I hope everyone can see this. It's about a 50-year-old woman who presented with a painless lump in her right breast for a duration of 3 months. Anyone who want to say how are we going to investigate this patient? Any student, please? Just to save time, and we need a lot to discuss.
So her management would be based on the triple therapies, the triple assessment. So
Triple
did you get a
assessment. So that is done. After triple assessment, what is the imaging we are doing? So I have
imaging?
given you the answer. Imaging is she's 50, so she is 40, more than 40, so we will do a mammogram, isn't it? Hello?
Yes, sir. Yes, sir.
Right. So we will do a mammogram. The first investigation, the imaging. So, and it has showed a speculated hyperdense lesion in the upper outer quadrant with architectural distortion and classified at BIRATS 5. So you all need to be familiar with this BIRATS classification, which is breast imaging reporting and data system. It has 6, 1, 2, 3, 4, 5, 6. 1 and 2 is normal breast. 3 is suspicious, but more towards benign. 80% will be benign. 4 suspicious, more towards malignant. 80% will be malignant. 5 is malignant. And 6 is biopsy proven breast malignancy. So there are a lot of information that you can gather with the mammogram. The imaging that you will see is a speculated hyperdense lesion, architectural distortion around the lesion. There can be microcalcifications associated with it, which will point towards DCIS pathology as well. So when you say microcalcifications, all microcalcifications are not malignant. Remember that 85% of the microcalcifications are not malignant. The microcalcification that will depict malignancy are the ones, those are pleomorphic and heterogeneous, which are less than 5 millimeters in size. So there's a very peculiar pattern that you will see in a mammogram, the microcalcifications, which will be malignant looking microcalcifications. And sometimes there will be all-line skin edema if there's an involvement of the lymphatics as well. So the next mammogram, so the next imaging would be the ultrasound scan. So I told you first, it's a very focused assessment, and the measurement of the cancer, the lesion, is also very accurately done with the ultrasound scan rather than the mammogram. And it will see, and it has showed there's a lesion 2 centimeters, and when they see the axilla, there were no suspicious lymph nodes in the armpit. And we have done an image-guided core biopsy, and it has showed an invasive breast cancer, NST. NST means no special type. So these are ductal cancers, but ductal cancers vary papillary mucinous. There are different types that will go. So adenocarcinomas. So NST means there's no special type. These are just ductal cancers. It's grade 2. When you say grade, it's the Nottingham grading that we are talking about. There is 3 gradings: 1, 2, and 3, depending on the features that we see under the microscope: tubular formation, nuclear pleomorphism, and mitotic count. So each parameter is given a score of 1 to 3, and so the maximum score will be 9, lower score will be 3. 8 and 9 out of 9 is 3. 7 and 6 is 2, 5 and below is it's grade 1. So this is grade 2 cancer. And when we do the immunohistochemistry with the core biopsy, it says it's ER8, PR6, and HER2 negative. Now, this is the other advantage of doing a core biopsy rather than a cytology, because we can have the immunohistochemistry, which is very important in determining the rest of the management of breast cancer patients. So, immunohistochemistry, we customarily check 3 components: receptor sensitivity for estrogen receptors, progesterone receptors, and the HER2. So, depending on the receptor status, there are 4 variants: hormone receptor positive, HER2 negative ones. So that is the best combination to have, because that combination will have a very good prognosis. And hormone receptor negative, HER2 negative, what we call the triple negative group, will have a very bad prognosis. They tend to be sometimes genetic as well. I come to that later in this presentation. Then the hormone receptor negative, HER2 positive ones, that is also a very bad group, because when the HER2 factor is overexpressed, they tend to recur in other parts of the body like liver, lung, brain, those organs. Then you have the triple positive group, which is the hormone also positive, HER2 also positive. So then you have to treat it for targeted therapy plus hormone therapy. Any questions from this slide? Am I too fast, or is it too much information for you all? Can I continue then?
Yes, sir.
Right, okay. Any of you are free to stop me at any point. I'm happy to clarify anything that you want, right? So when we do a wide local excision or a breast constitutive surgery, the principal, the standard practice is to do what is called the intraoperative specimen mammogram to assess the margins. So this is example of a specimen mammogram of a patient I have done. So you can see right in the center. Can you see that my arrow moving?
Yes, we can see. Yeah, you can go ahead there.
So that is the cancer, the hyperdense lesion, which is the cancer. And these are the margins. That's the lateral margin I have marked with 2 Liga clips, and that's the superior margin I have marked with the 1 Liga clip. So that makes this the inferior margin, and this bottom one is the medial margin. So the radial margin, it's all good, isn't it? What we need oncologically is a 1 millimeter clearance from the for invasive breast cancer, and 2 millimeter clearance for DCIS. So this is done. If for example, if this margin was here, that is the inferior margin. If this was here, then I would have to take another shave from that inferior cavity, and I can do it at the same time, the first surgery, rather than waiting for a second time. So that's the beauty of doing intraoperative specimen mammograms. It will cut down the redo surgeries in breast conservative surgery. So this is what the standard, the practice in at Ragama. We do this, though we have tremendous support from the radiology department. Whenever we ask, when we do the breast cancer test, they are geared to help us these mammogram of the specimens. So that patient, what is the next management? So we have done we have done the investigations, and so it was a 50-year-old woman with a 2 centimeter lump. Lymph nodes are not involved, so we can do a wide local excision, a breast conservative surgery, and we have, because the lymph nodes are not involved imaging wise as clinically, we can do what is called the central lymph node biopsy. What comes hand in hand with breast conservative surgery is adjuvant radiotherapy to the lateral breast, because in a mastectomy we will be removing the cancer as well as the rest of the breast as well. But in a breast conservative surgery, we are removing only the breast cancer. So the rest of the breast tissue will be treated with radiotherapy. So if you are talking about a patient to undergo breast conservative surgery, what comes hand in hand, which will be followed by radiotherapy. So if your patient has any contraindications to undergo radiotherapy, you cannot offer breast conservative surgery or wide local excision for that therapy for breast cancer. For example, if they have these soft tissue conditions like systemic sclerosis, or they have had radiotherapy before, then you can't give radiotherapy again. So you can't offer a wide local excision in that scenario. Otherwise, when you offer wide local excision or breast conservative surgery, which will be inevitably followed with, has to be followed with, mandatory with adjuvant radiotherapy to the breast. And we give whole breast irradiation, but we mark the tumor bed with legal clips. In the CT simulation, they can pick the tumor bed then, and if the patients, sometimes we give a tumor bed booster dose, radiotherapy booster dose, apart from the whole breast radiotherapy, but there are very few indications for that. We don't need to go into that detail. And because these patients having a ER/PR positive cancer, we can treat with aromatase inhibitors. So remember this, patients who are postmenopausal and having a hormone positive cancer will be treated with aromatase inhibitors and not with tamoxifen. Tamoxifen is given for patients who are premenopausal and having a hormone positive breast cancer, right? So aromatase inhibitor, we have 3 drugs. Only 2 are available in Sri Lanka, which is anastrozole and letrozole. The other one is exemestane. Exemestane is not available in Sri Lanka. Exemestane is a steroid-based one, which is good, but it's not available. Anastrozole and letrozole is a non-steroidal aromatase inhibitor. It is available in Sri Lanka. Is this clear? Can I move forward, or you have any questions, anyone? Okay.
Yes, sir.
Yeah, go on.
For that patient in the sentinel lymph node biopsy, if that became positive, she would require chemotherapy additionally, or?
That's a very good question. So once we do the sentinel lymph node, it will be subjected to histopathologist for the pathological analysis. So if it comes negative, that's fine. Then they will not need any other therapy. Then we stick to our plan. We give radiotherapy to the breast, AI aromatase inhibitors for 5 years. That's it. But as you said, if it comes positive, the sentinel lymph node, 20% of the chance it can happen. If it is positive, you don't need to go and redo the axillary surgery. We don't do that, right? Because even if you do that, still 80% will be negative. Redo axillary care, completion of axillary care. So now it is not done. You can, when you are irradiating the breast, you can irradiate the axilla as well. Okay. So to complete the end, you will give, because now the nodes are positive, as you said, you will give chemotherapy as well. Otherwise, not chemotherapy is not needed. But because the lymph nodes are positive, we will treat with chemotherapy, and we will cover the axilla also with the radiotherapy. So the local recurrence and the systemic recurrence will be dealt with. Am I clear?
And she will also be requiring anastrozole for 5 years.
It will be given. Endocrine therapy will be given anyway.
Thank you, sir.
Right. So the next scenario is a same patients, but a different tumor, right? So having a 50-year-old woman, painless breast lump, right breast, 3 months duration, and the mammogram showed the same findings. And now this is a 3 centimeter lesion, and the lymph nodes are involved. Ultrasonically, lymph nodes are involved with it has an altered fatty hyla. Core biopsy, same scenario, and now the immunohistochemistry, it says ER8, PR6, and the HER2 also positive. So it's a hormone positive and a HER2 positive. It's a triple positive cancer, right? So now what is the management? Right?
So if it's more than T2N1, you have to manage it as a locally advanced carcinoma, which would be a neoadjuvant therapy followed by surgery.
Yeah, that's a good option. Yeah. Anything else? We have two options.
And hormone
This is the first option, as you mentioned. Yeah, go on.
additionally given after the salvage mastectomy or hormone therapy and immunotherapy for the HER2 and ER/PR positive.
Yeah, not immunotherapy, targeted therapy. So first option is you can give neoadjuvant chemotherapy because lymph nodes are involved and it is HER2 positive. HER2 positive patients tend to respond very well for neoadjuvant chemotherapy as well as the triple negative ones. So you give neoadjuvant chemotherapy plus Herceptin because the HER2 is positive. Herceptin is the brand name or the generic name of the targeted therapy is trastuzumab. So you will be in your question paper, you will get trastuzumab. Okay, that is the generic name of the targeted therapy for HER2 positive patients, which can be followed with a wide local excision, axillary clearance because the lymph nodes were involved, and followed with radiotherapy and aromatase inhibitors. That's a good option. What else? Or you can do straight away wide local excision, axillary clearance, followed by chemotherapy, Herceptin, and radiotherapy, and AI. AI is aromatase inhibitors, right? So if the patient doesn't want, if you can't convince them to have neoadjuvant chemotherapy, which is sometimes very difficult in Sri Lanka, you can offer them surgery. And sometimes they tend to agree with the treatment, chemotherapy afterwards. So the first choice would be to give neoadjuvant chemotherapy, but don't split your hairs. If they don't agree, you have a second option as well. First option is the best because they will do well with neoadjuvant chemotherapy with the HER2 positive ones. Now, if you are giving that's the second option. Now, if you are giving a neoadjuvant chemotherapy for a breast cancer, and if you are going to do a wide local excision later, what are the problems that you should anticipate?
So before giving neoadjuvant chemotherapy, the tumor, after giving neoadjuvant chemotherapy, the tumor might no longer be there afterwards.
Fantastic. So what can you do? So how are you going to do wide local excision then? Because if you can't palpate the tumor, if you can't see it, how can you do it? Wide local. So what are the options?
We had to restage with the imaging triple assessment.
So you do imaging, it says you can't locate a tumor, it's no longer there. Because sometimes 20% of the time, neoadjuvant chemotherapy will give you complete radiological and pathological response.
So we can just follow up with the Herceptin.
That has been tried in few trials in Manchester and in somewhere else in UK, and they had to discontinue the trial because of the recurrence. So it
So we
is
can
true
do
for
clipping
colorectal
session.
cancer. In colorectal cancer, in rectal cancers, they do what is called the total neoadjuvant therapy, TNT. And if they respond, complete clinical and pathological response, radiological response, they can follow up, but not for breast. Probably.
Mark the tumor.
What is,
Mark,
how can you overcome this problem?
We can
mark
do
the tumor.
clipping sessions. Marking the
Yes,
Marking the tumor.
yes, that's true. So before starting the neoadjuvant chemotherapy, we can mark the tumor with a clip, with the Liga clip under image guidance, ultrasound guidance. We can put a clip to the center of the lesion as well as to the periphery of the lesion. So we know where the cancer was. So even if the tumor is no longer palpable after neoadjuvant chemotherapy because it has responded well, we can identify the clips from the ultrasound scan and pass a wire to the center of the where the tumor was, and do a wide local excision. And we do the excision when you do the specimen mammogram, we can see whether all the clips are involved in the specimen that we have taken. So that is how you overcome them, right? Wonderful. So, slightly different scenario. This is a 40-year-old woman coming with a 3 centimeter triple negative breast cancer. That is, ERPR is also negative, HER2 also negative. So I told you triple negative carries a very poor prognosis, right? But there are no clinically or radiologically no lymph nodes. Now, how do you manage?
We might have to do a genetic panel for this patient, sir.
Right. Why do you think so?
So because she's a 40-year-old woman, and it's triple negative breast cancer, so that's usually associated with a genetic involvement.
Really speaking, not so, but it's like this. I will come to gene positive breast cancer. I will answer a question there because it will be better, everybody will understand better there. So at the time being, I would, it's not a total no, but you can consider that fact. What else? Okay, so it's always neoadjuvant chemotherapy because the guideline says if it is the triple negative cancer is more than 2 centimeters, it's better to give neoadjuvant chemotherapy because the long-term results, the prognosis would be better. And if they have lymph node involvement on top of this, then anyway they will need neoadjuvant chemotherapy, right? Yes, we can do a wide local lesion and a central lymph node biopsy. Adjuvant chemotherapy. All triple negative breast cancers will need chemotherapy after the surgical treatment. And because we are doing a breast conservative surgery, we will do a radiotherapy. If this patient for any reason undergoes a mastectomy, she will not need radiotherapy. Okay? Okay. Now this patient, a 28-year-old woman with 4 centimeter triple negative breast cancer. So we will do neoadjuvant chemotherapy, wide local excision, SNV, adjuvant chemotherapy, radiotherapy. Now what else?
So it might
Yeah, go on.
so it might be BRCA1 positive, so
Yeah.
we have
So
to
this
consider about mastectomy.
wonderful. So what this patient needs genetic testing. So the in a crude manner, how I explain this, there are different ways to be certain when to do a genetic testing in breast cancer patients. But as a crude method, for you to understand, any patients who are less than 30, irrespective of their family history of breast cancer, whether they have it or not, you will do a genetic testing to see the BRCA1 and 2 involvement, right? Patients who are 30 to 40 will undergo a genetic testing if they have a breast cancer plus there's a relative with breast cancer. That is a first degree relative with a breast cancer. For example, they are 35, they have breast cancer and their mom also had breast cancer or their sister also had a breast cancer. So they will also undergo genetic testing. Now 40 and above, right? You will think of doing a gene testing if they present with one thing, that's a triple negative breast cancer. That's a minor factor. Another thing is if they have bilateral breast cancer, they present with bilateral breast cancer, synchronously, right? Then you have to do a genetic test. If this patient's genetic testing is negative, you can do wide local excision. But if, as you mentioned, if the gene becomes positive, either it's BRCA1 or 2, then you will have to do some sort of a mastectomy. Now here, we value what is called the conservative mastectomy. I mentioned you in the first few slides about nipple sparing mastectomy and skin sparing mastectomy. This is an indication. This is the patient who will benefit from one of those. And also, if the genes are positive, you will think of doing a prophylactic mastectomy to the other side. But that has not to be done at the same sitting, but it can be a later date, but it has to be done. Now, the famous scenario is about Angelina Jolie, the world famous actress. She underwent bilateral nipple sparing mastectomy prophylactically. Bilateral. She didn't even have a breast cancer, but her siblings had breast cancer, so she was under a lot of risk to develop a breast cancer. Although she did not have, she underwent bilateral prophylactic mastectomy with reconstruction. Okay, so that's how the world moves, right? Do you understand about gene testing and how to go ahead with that? Anyone, any questions?
So if there's a male member with breast cancer in the family, does that increase the risk even more?
That's a fantastic question. So if you have a female relative and the index patient's breast cancer risk is high, but if you have a male member in your family with the breast cancer, then the index patient is breast cancer risk is higher, much higher than having a female member with a breast cancer. Am I clear? Is that clear? So, for example, if your mom had breast cancer, you have risk of developing breast cancer, we say 10%. But if your dad had breast cancer, your risk of developing breast cancer is like 30%. Is it clear? Hello?
Yes, sir. Thank you.
Okay. Any questions about anything about genetic testing? And what else, if genes are positive, what else should you think about? The ipsilateral breast, what you do? The contralateral breast prophylactic mastectomy, then what else? What are you going to do about the ovaries? Isn't it? Because BRCA1, 50% will develop ovarian cancer. BRCA2, 80% will develop ovarian cancer, 60 to 80%. So you have to prophylactically remove the ovaries as well. So it's like opening a Pandora's box if you are going to check their genes. Right? It's not a joke. So if you have to counsel against first, rather than asking them to get the testing, you have to counsel about the possible effects, not only to the index patient per se, but if they have a sibling and when they become that your sister is having a gene positive breast cancer, their life is also achievable. So you need to address those issues, counsel them before doing a genetic testing, right? So if they have not completed their family, before going the neoadjuvant chemotherapy, because with the neoadjuvant chemotherapy, you will damage the ovaries, ovarian function will be lost. You have to do what is called the ovarian preservation therapy. Either you give the neoadjuvant chemotherapy with GnRH analogs like goserelin to suppress the ovarian action so that the hit by the chemotherapy to the ovaries will be less, or you can preserve the eggs. We can do that. Although it's costly, the government sector doesn't support, but the private sector, you can preserve the eggs before starting the chemotherapy, neoadjuvant chemotherapy. We isolate and preserve the eggs and freeze them and save them, and then subject to chemotherapy. And later, if they want to have a baby with a family and a family life, they can have a baby. So there are a lot of things to discuss around a gene positive breast cancer. Okay, and even if there is a triple negative or a hormone positive cancer with a gene positive breast cancer, we can allow them to have a family. We can allow them to undergo a pregnancy. We allow those things, right? But the time frames has to be discussed case by case. All the decisions will be made in an MDT setup, multidisciplinary team meeting. Okay. So in your answers also, you have to, if you are discussing the answers in a long case or SCQ, you have to tell that everything will be discussed in MDT setup. So in that case, if the genes are positive, white local will be not a good option, but do a conservative mastectomy with implant reconstruction. Because these are young women who sometimes they are unmarried women, you can't do an autologous breast reconstruction because you can't take their tummy tissues. We preserve that for a future pregnancy, so we can do an implant breast reconstruction. But for patients uh, who have completed their families, we can do autologous reconstruction with abdominal flaps or back muscle flaps. Okay, another case. So now this is an 85-year-old woman who is ASA3 with a 3 centimeter breast cancer, no lymph nodes, ER8, ER7, and HER2 negative. So what are the options?
Chemo and hormonal therapy?
Yeah, those things will be done. Mammogram, all these things will be done. What are the surgical options? So mammogram, ultrasound scan, the biopsy, everything done. That's why we had immunohistochemistry, the grading and everything. So what are the options? So we can do a mastectomy or a wide local excision and give aromatase inhibitors because it's hormone positive. I have put mastectomy stroke wide local. Now don't think because she's old, she has to undergo a mastectomy. It's not that so, right? Breast is very unique organ for the identity of a woman, their physique and identity as the image identity. So breast is very important. So age is not a factor that we consider in deciding a mastectomy, right? It's the patient's choice. So if I ask a question for you, you all must be in your 20, so between 20 to 25 or 30s. If you have a breast cancer in a hypothetical scenario, would you like to have a mastectomy or wide local excision? Most probably wide local excision. And in your 50s, would you like to have a mastectomy or a wide local excision? I guess it's the same, wide local excision. What about when you are 70? It's still you, isn't it? So you always give the option. But if the patient says they would like to have mastectomy, these are for logistical issues sometimes because they are living alone. They cannot travel for radiotherapy. So they would they would like to have a mastectomy instead of a white lobe. So I want to highlight that point because even the practicing surgeons as well as the junior doctors also believe, well, she's old, she doesn't need a breast conceal, she can undergo mastectomy. Don't decide on behalf of the patient because it's the patient's unique choice. So now I have not put any axillary surgery for the first option, have I? Because if the lymph nodes are not involved clinically, mammographically, or ultrasonically, there's no point in doing axillary surgery, even center node biopsy. Patients who are 80 and above, we don't do that. But if the image says lymph nodes are involved, we will do a clearance. Otherwise, we will not touch the axilla. Because for her to develop axillary disease as a recurrence and to end her life with that, before that, she will have a natural death. So there's a study called the age gap study in UK. The conclusions are, if you're 80 and above, you don't do the axilla if it is clinically and radiologically negative. Right? But in your exam, you might offer sentinel node biopsy, and if your panel of the examiners in the discussion panel, if they ask what to do, you can give this explanation, or you can say, okay, I will do a sentinel. Right? But I have said that she's ASA3. So there's an immediate risk of giving her general anesthesia. So if her heart is not good, for example, she's having AF, she's ejection fraction is 20, and there are evidence of pulmonary hypertension, there's an immediate risk of death on table if you give GA. Okay, then there's another option, right? What is that? Because she's hormone positive, you can give what is called the primary endocrine therapy. That is to start her on aromatase inhibitors and continue on that. But here, not for not for 5 years, until her lifetime, right? She might die at 90, then it will be till 90. She might die at 95, then it will be till 95. Right? Because we are not giving anything else. We are just giving the endocrine therapy, the aromatase inhibitor. So it will be the primary therapy that we give. So it's primary endocrine therapy, lifelong. Am I clear? Is this slide clear to you all, what I said?
Yes, sir.
Right. Okay, so I'm going to show some photographs of patients we have done the surgeries that I explained. Are you all happy to go there, or you want to discuss any theory here before we go there? Any questions?
So what's the general management of metastatic breast cancer?
That depends on where the mets are and what sort of mets are. So in basic terms, if the mets are in your bones, and if that is a single area, for example, your L4 has a met, so then we can irradiate give radiotherapy to the L4, the met, and we can subject to what is called the zoledronic acid. The best would be the denosumab, which is not available in this country. We can give zoledronic acid, okay, to increase the strength of the bone, and subject, if they were already on aromatase inhibitors or tamoxifen, we can change that to what is called the full strength or Faslodex. It's another therapy of modulator of endocrine therapy, which is not they have a different action to AI. And with or without, you can give chemotherapy. On the other hand, if you have mets in your liver and the patient is symptomatic, for example, pain or they are loss of appetite, we can give palliative chemotherapy. That chemotherapy could be IV or even oral, like patients who are not fit enough to have another round of chemotherapy IV, they can be given what is called the oral capecitabine therapy. And if they are having mets in their lungs, you have to see how symptomatic they are. Sometimes they are very symptomatic, they have pleural effusions, then you have to dry the pleura by aspirating and doing what is called the pleurodesis, right, with talc therapy. Then you will seal off, and hopefully the lungs will be dry after that, and you can give palliative chemotherapy as well. Other patients, sometimes these HER2 positive patients and triple negative patients, they tend to recur sometimes in the brain. If that happens, the management is they develop severe pain, headache due to the swelling, perilesional edema, right? So you manage that with dexamethasone. With high dose of dexamethasone, the perilesional edema goes down. They will get recovered from the headache. And the other thing is, when the dexamethasone is given high doses, it will disrupt the blood-brain barrier. Once the blood-brain barrier disrupts, we can give chemotherapy. When the chemotherapy is given, it will reach the brain through the blood-brain barrier because it's now disrupted. And after that, we can irradiate the brain as well, radiotherapy to the brain. Am I clear? I'm just trying to
Yes, sir.
simplify things for you.
So then, in metastatic disease, is the management of the breast different?
Yeah. Now, metastatic breast cancer, when we say, it can be after this initial management, where, for example, patient came, we have done the surgery, they are on endocrine therapy or not, and after 1 or 2 years or 3 years, 4 years, during surveillance, they develop metastatic breast cancer. So then we do the subsequent what is necessary for the metastatic areas. But rarely patients present with metastatic breast cancer. That's the initial presentation, right? So for example, today also I met a patient. She's 28 years. She was in Italy. And she developed this dyspnea on exertion and taken to the hospital. They did the chest X-ray, the massive pleural effusions on both sides. Then the subsequent investigation, blah, blah, they finally diagnosed as a large mass, malignant mass in the left breast. Okay, now after that, she came today, she has come to Sri Lanka and came today. So we are now geared up to give her chemotherapy, neoadjuvant chemotherapy, right? So in that patients, so we have to deal with the complications, give the palliative chemotherapy, start the chemotherapy, and depending on the response, we can offer the surgical management. For example, if that patient has a good response in a breast, we can give a nipple sparing mastectomy. We discuss the options of genetic testing, to which they agreed, and we see those results as well, and do the subsequent management. Sometimes they present with very local advanced ulcerative breast cancer. So in that case, we will have to do what is called the toilet mastectomy and cover the skin, with a skin graft or a flap. So it depends on how the presentation, if it is a delayed presentation or an initial presentation. But the surgical options, you have to always discuss with the patient, which we do to the breast. Don't have this idea, reconstruction options are only for young patients, only for the patients who are not who are having early breast cancer. It's not so. Reconstruction option is offered to each and every patient, irrespective of their age, irrespective of their stage of the cancer. Okay, it's their right. So I will tell you another story. The oldest patient I have done breast reconstruction, a total reconstruction in this country, is 76 years, right? I didn't even talk about reconstruction. She had a very advanced cancer. What she told me, doctor, if you are telling me I have advanced breast cancer, and if I'm going to at least live 6 months, I will live that 6 months to the fullest of my life. I don't want to be flat-chested, lopsided on one side. I don't want to have a social stigma. I want to have the best quality of life for the next 6 months, if you say so. So, what do you understand? And that patient was so motivated and so up for it. The next day, after 8 hours surgery, next day when I go to the ward, she's walking in the corridor. Right? So that's why I say, if you see the contraindications or the cautions for breast reconstruction and wide local is going day by day. So now the current thinking is, irrespective of the age, irrespective of the stage, you will offer breast conservative after discussion with the patient. So if they are willing to have it, if they want it, you can do it. Am I clear?
Yes, sir. Thank you, sir.
Right. So now it's more than 1 hour. So just go through the surgical options. So can someone say which faculty students are joined today? Is it Wayaba only? Wayaba students are there? Yes or no?
Yes, sir.
Right. Any other faculties? Please say so.
Sir,
Yes,
Kennedy. Kotalawala Defense University.
Where?
Kotalawala Defense University.
Fantastic. Who else?
Sir, Rajarata Medical Faculty.
Okay. Who else?
Kalaniya, sir.
Okay. Who else?
So Jayawardhan College.
Okay. So we have about 4-5 faculties. Fantastic. So I will go through one by one. Some of you may not have seen, some of you might have seen. That's okay. For the people who are not seeing this, to have some glimpse of idea. So now this is a patient. So this is a patient after surgery. She had a right breast, right lower, 6 o'clock position, breast cancer. And we have done a wide local excision. And we have done you can see there is no incision in the breast. Her cancer was here. You can see the arrow I'm moving, right?
Yes, sir.
Yeah. So her cancer was here. There's no scar in the breast. So what we have done is we have go in the inframammary fold lift it up, remove the cancer, did a wide local excision, and there was a huge defect. You can imagine that there can be a huge defect here. But we have filled that defect with what is called the ICAP, anterior intercostal artery perforator flap, one of the chest wall perforator flaps. So flap was also raised from this area and fill it up. You can see the side profile as well as the anteriorly. The breasts are more symmetrical in terms of size and shape, isn't it? So these are wide local excisions, and we have gone further step, which is called the chest wall perforator flaps to fill the defects. That is part of the partial breast reconstruction. So now this patient, look here. Now this is the patient after 3 months of surgery. She had a lateral cancer, right lateral breast cancer. This is the scar. So we have done this. The entire breast is gone. Lateral half is not there, right? This is from the latissimus dorsi flap we have harvested, right? So we are creating symmetrical looking breast. And this is a patient who was referred from Polonnaruwa. She's a young girl. She's only 24, 25. They have done a excision biopsy of a breast lump. This is not, you can see the scar. This is not ideal scar to do a incision to do a breast lump excision. But ultimately she has undergone a breast lump excision. They have taken the skin over the lump as well. And you can see some pulling of the skin towards that side. And that lump turned out to be a malignancy. She's only 25. When we do the genetics, that is also becoming positive. It is BRCA2 positive. So then sent for us to do the rest of the therapy and the reconstruction. So we have given her neoadjuvant chemotherapy. You can see that still she's wearing a cap here. Yeah. So she underwent neoadjuvant chemotherapy, and then we did a nipple sparing mastectomy, but we couldn't do a proper incision because I'll be creating another scar. So I went to the previous incision, which she had already, and did a nipple sparing mastectomy. Entire breast parenchyma was taken out, and we did an implant breast reconstruction. Okay, so that breast volume is okay, but there are slight discrepancy in the symmetry. That's because the skin loss that was created from the initial surgery. Now look at this patient. This patient came with what is called the Paget's disease of the breast. She was only in her 45 or 46. She had a Paget's disease of the breast. She came with a non-healing ulcer in the nipple lateral complex, and she has undergone a lot of ointment, treatment, creams to apply to that, thinking it's eczema from her GP. But when we investigated further with the punch biopsy, it showed that it was a Paget's disease, and it has underlying cancer as well. So she underwent what is called the central excision, a wide local excision, including the nipple lateral complex, and we have removed everything. That's the scar, and this is, we filled that with the LD muscle, and this skin island is from the back here. So now she is away. This is about 1 month, 6 weeks ago. Now she is awaiting for a nipple reconstruction. We can create a nipple like this on this side now. It will be done under local anesthesia, right? Okay, fine. Now look at this patient. This patient is in her 38, 39 years. She came with a right-sided breast cancer. Now this is after surgery. We have done a nipple sparing mastectomy here, right? We have done the nipple sparing mastectomy. That's the scar, if you can see. That's the scar, the right side. And I have done a abdominal flap reconstruction. That's the scar in the abdomen, and the scar, the neoumbilicus, right? So the side profile is also normal. So there are options for reconstruction. I mean, wouldn't it be better to do a reconstruction if it is possible, rather than having a flat chest and lopsided? So there are options available. If you and you have, it's your duty to talk and give the discuss and with the patient and the family to give the options. for a better outcome. So you need to, the priority is on oncological clearance, safeguard the patient from the cancer, as well as for them to have a better quality life. Any questions?
Nalinda, can I ask a question?
Yeah.
Yeah. Okay. Assume that there is a patient with suspicious lesion like BIRATS 4-5 and repeated guided biopsy came negative. What will be the next option?
So internationally accepted is you do up to 2 repeated co-biopsies. So you do the
Yeah.
first biopsy, and still if it is negative, do a repeated co-biopsy. The problem is the size of the course that you take. So what is done in Sri Lanka is 18 gauge needles, which is not adequate. You have to do from 14 or 16. The better option would do 14 gauge core biopsies. So when you get a 14 gauge core biopsy, you take a bigger chunk and less tissue trauma. So the yield, the outcome by the pathologist will be better. But if that is both biopsy twice is also negative, then you can go for a excision biopsy.
What about needle localization biopsy, Nalinda?
Needle localization biopsy is done for impalpable lesions. So if the lesion is palpable, you can do a normal excision biopsy. But if the lesion is not palpable, but it is seen with the ultrasound scan, you can do a ultrasound guided localization with a wire and do a wire guided biopsy.
Okay, right. Another one, what about that management principle for fibroadenoma?
Yeah, fibroadenoma, there are no consensus, but you need to understand there are 2 fibroadenomas. Commonly, what we see is a simple fibroadenoma, BIRADS 3 or 2. It should be labeled as BIRADS 2 if it is really fibroadenoma, but radiologists label sometimes it as 3 as well. In principle, if a lesion is 3, you have to do a biopsy. But lesion is 2, BIRADS 2, you don't have to do a biopsy.
Okay,
A solitary fibroadenoma less than 2 centimeters, there's a 40% chance that it will regress with time the next 1 or 18 months, 1 year or 18 months. So you give that chance. Fibroadenomas are more than 2 centimeters, they rarely regress or they do not regress. Then you will discuss the options with the patient. Then you will have, if the patient, first option is to leave it behind, but if you are leaving it behind, you have to do a biopsy and then confirm it's normal, and then do once in 6 months or 1 year ultrasound scan to see if there are any interval changes, or else you will remove it. Fibroadenomas more than 2 centimeters, yeah, you have to offer them excision. Sometimes 20% of the time, patients develop bilateral fibroadenomas and multiple fibroadenomas. This is a huge headache. So one patient will be having 10, 15 fibroadenomas in one breast. Now, please don't understand, we are going to hunt down each and every lymph fibroadenoma. It's not so. If there is vascularity inside, if the lesions are more than 2 centimeters, if they are cosmetically bothering, if the lesions are in the nipple areolar complex compressing over the duct system, then we will offer. Otherwise, we will not offer. If they want to have all the fibroadenomas removed, then we do what is called the inframemory incision fibroadenoma excision. So there will be no scars in the breast. So we will hide the scar in the inframemory fold, and we go under the parenchyma, breast parenchyma, and take down the fibroadenomas.
Yeah, another one.
Yeah.
Is there still a place of frozen section in sentinel node biopsy, Nalinda?
So this was started in Europe as well, and we did this as well in Sri Lanka. But now the place for frozen section with imprint cytology, it's gone. It's not there. So because now the initial idea, in theory, it was saying the first lymph node to affect with the blue dye or the radioactive tracer, we harvest it and then we subject it to frozen section or imprint cytology. And if it is positive, we take the all the lymph nodes down at the same time. And if it is negative, we leave it. But the understanding is that even if that node is positive, and if you do a complete X-ray clearance in the same sitting, rest of the lymph nodes are negative 80% of the time. So you have taken down the entire lymph node basin just because this central node was positive, but the rest is negative 80% of the time. So that's why the world has put that aside and they are not practicing it. So if the central node is positive, you do X-ray radiation with the when you are doing the radiotherapy.
Okay, thank you very much. Any
So-
more questions? Yeah.
Sir, for locally advanced breast cancer, if we're going ahead with the breast reconstruction, does that require more frequent follow-ups than if we did something like a mastectomy?
No, the follow-ups are the same. Follow-ups are the same. Now, important to have this understanding of surveillance. So, surveillance, when you're doing it's annual mammograms for the next 5 years. After that, they will be going to routine recall with the mammograms once in 3 years. Then they will do the bone scan, CT scan of the chest, abdomen, and pelvis. Then we do that is about 1 or 2 years per 1 or 2 years CT scan. And we can do ultrasound scan in between to assess the liver. And the breast we assess with mammograms. On top of that, younger patients who has undergone for implant reconstruction, we can do a ultrasound scan. Your question whether those patients need a more aggressive follow-up, it's not so. It's not so. Unless they have developed meds, and then we will deal with that in a different way.
Right. Thank you, sir.
Okay, thank you very much, Dr. Nalinda Munasinghe. I think he's the ideal person to discuss about management of breast diseases. That's why we contacted him and asked to do this kind of presentation. I think you realize that this is a very valuable, meaningful discussion for your final MBBS examination. Thank you very much, Nalinda.
Thank you. Thanks for
Giving
giving
you.
the opportunity.
Yeah. Then regarding the next webinar tomorrow, it will be about colorectal surgery. It will be done by Dr. Vidu Disilla, head of the department, Ruhuna University. Thank you. Good night.
Thank you, sir.